And today I'm going to talk about the Karolinska Policlinic for post-infectious diseases, a little bit about clinics and research. And I will start talking a little bit about my background and my background in ME/CFS, previous to working here, because it has influenced how we arranged the new clinic. So if I... Okay, no, I have no declaration, conflicts of interest, let's see. Yeah, that's the one. Up to this. So this is about my background. I'm an MD PhD. I did my PhD in neuroimaging in cognitive disorders, mild cognitive impairment and Alzheimer's disease. I specialized in rehabilitation medicine, focusing on brain injuries really. And then I was a research physician at AstraZeneca, working with imaging biomarkers mainly in neuroscience. And then I've been involved in clinical and research work with ME/CFS since around 2010, except for a couple of years where I returned to more other neurological rehabilitation like Parkinson's, stroke, brain tumors, and Huntington, epilepsy, and stuff like that. And now I'm a senior consultant at Karolinska University Hospital since 2021. Let's see. And this is about my experience of ME/CFS. I worked with two different clinics or projects and clinics with assignments from the county, so publicly funded clinics for ME/CFS, but they were mainly focused on rehabilitation, the assignment from the county. And so there were some negative factors that we discovered, that the resources were not really based on the clinical or research needs for the ME/CFS patient group. And we weren't part of the resources of a university hospital really. And we had to kind of go around the original assignment to provide the care we discovered the patient needed. But the positives were we tried to provide adequate medical investigations, treatment, rehabilitation. So it's quite complex. But we learned also that the ME/CFS clinic needed resources of a university hospital, really. And we learned the importance of multi-professional teamwork for the patient group. And we learned the importance of dialogue with the patient organizations. In Sweden, there's a Swedish ME organization, RME. It was RME that got us in contact with a lot of both regional, national and international clinicians and researchers, and also with Invest in ME, for example. So I wouldn't be here if it wasn't for the Swedish patient ME organization. So they have a very important role. And we could do some research. I have some very quick examples. I won't go into details. We were able to look at blood flow changes in the brain with ME patients, small studies, but I think there are more studies of this now. And we looked at increased levels of autoantibodies in ME/CFS together with Jonas Bergqvist and Carmen Scheibenbogen. Let's see. And we did a treatment study with kind of cranial nerve stimulation that could reduce some symptoms and seem to affect the immune system, together with immunologist Petter Brodin and ENT specialist Jan-Erik Juto developed this method that is approved in Sweden for chronic rhinitis and have shown effects in migraine. So it's a bit interesting. I can see I have this pointer. We use a symptom score based on the Canadian criteria, really. You can see, oh, this is a bit complex picture, but the patient group that get the full treatment for 8 weeks, 16 treatments, they improve by 30% in the score. It's quite large effect, and the placebo effect is around 10%. So it's interesting. Let's see. And this is from last time I was at this meeting. I think maybe some people in the room can find themselves in this photograph. I think it's clinicians meeting in London. So this was 2019. And for me, it's coming back 6 years later. It's really inspirational to be here this week and see the number of people here and the width. And it's a very interesting research being presented. So it's interesting to reflect on this. And this was 2019, and we all know what happened later that year, the COVID pandemic. And the ME Polyclinic I worked in, we couldn't meet patients physically because of the pandemic restrictions, and that was the income in our deal with the county, so it was a problem for the clinic. And very early in the pandemic, I contacted the new head of the clinic who was a bit skeptical about ME, I must say. They really didn't understand what we were doing with this patient group, and it was strange. And I said, I'm afraid that after the pandemic, our experience will be in great demand. We'll probably get a lot of new referrals. And the head of the clinic said, I hope not. And then a few months later, they closed the clinic. So, but the good thing was that they started this polyclinic at Karolinska that I could join. Initially, it was for post-COVID only. But then the county decided, after a couple of years, that there should be a permanent clinic and it should be for post-infectious diseases more broadly. So we were, in fact, several people coming from the old clinic when we started here. So the target patient group is suspected post-infectious disease with significant functional impairment. There's a team-based assessment, and we have a wide consultancy with other specialties within the university hospital, and we are initiating treatment and rehabilitation. Unfortunately, we cannot follow the patient for a very long time. We have to refer back to the GPs and so on for most patients. And current staff, we are increasing over time, so now we're 6 physicians, not all full-time, but different specialties, and also you see nurses, social workers, psychologists, occupational therapists, physiotherapists, secretaries, and so on. And quite high demand. We're the only clinic in Sweden so far, so 45% of our patients come from other regions than Stockholm. And so we have a 1-year waiting list right now. We try to shorten that. We see about 14 new patients every week. So we have a kind of standardized assessment for the physician. Every patient meets a physician, physiotherapist, occupational therapist, and psychologist. We do some standardized things. The physician, of course, can be very individual. Sometimes the differential diagnosis is really tricky. So you have to do a lot of extra tests. So in that way, it's not standardized, but we have some standard tests. And as you have heard from several presenters, we have learned that screening for POTS is very important. I'll come back to that. Yeah, I'll go back again. Because after patient meet everybody in the team, we have a team conference where we can say the diagnosis and do we need further investigations, and then we can suggest the treatment or rehab for just this patient. And some patients we follow for some time to initiate treatment and rehab, and then try to refer back to GPs and the rehab in the community. What we do, it's hard, it would take a long time to go into all the details, but generally there is no evidence for any disease-modifying treatment. So we focus, of course, on treatment, symptomatic treatment for pain, fatigue, sleep problems, dysautonomia, etc., etc. But there's a lot of, you could go into a lot of details there for individual patients. But the physiotherapist can work with breathing problems, dysautonomia, POTS problems, occupational therapists with pacing, or they prefer to call it activity balance or strategies for daily activities and so on. And the psychologist can be more involved in patients that have some psychiatric comorbidity, like secondary depression or things like that, and also to maybe screen them more for cognitive impairment or assist the patient with that together with the occupational therapist. And we're also social workers. I thought what your discussion had before is sometimes very important, the whole living situation, financial situation, living with this disease and the functional disabilities. And in the hospital, not in our clinic, but we have refer some patients for dietitians, for example, or speech therapists. Yeah, back to, you've heard several times now about cardiovascular dysautonomia, and we've seen now that 40 to 50% of our patients have cardiovascular dysautonomia in some form. And there's treatment available, both pharmacological, some specific training and so on, and fluid and the supportive stockings and stuff like that. So it's really important to identify. And we have fortunate to, we have weekly conferences with a cardiologist, which is Artur Fedorovsky. I think he was here last year to present. Yeah. So we have learned a lot about POTS and how to diagnose and treat. Here's from a review he wrote a couple of years ago about autonomic dysfunction in post-acute COVID syndrome. So you see all these overlapping symptoms between POTS and ME/CFS. So that's what we learned. Always screen for POTS. Because this is an interesting patient example. It was a post-COVID patient, hadn't recovered after the infection, 50 years old. She was an assistant nurse in a pediatric ward. She had post-COVID. The problems she had was severe fatigue, but mostly severe dyspnea. That was her complaint. And no palpitations, no orthostatic problems, no cardiac chest pain. She was on 100% sick leave since the infection. The chest CT showed this type of ground glass changes you can have as a part of post-COVID. And also EDAC, what's a new term for me at that time, it's called excessive dynamic airway collapse. The larger airways collapse when you exhale. So, and spirometry shows some obstructive, some asthma signs. So she got asthma treatment, this machine for CPAP, continuous positive airway pressure treatment during night, and breathing training with a physiotherapist. So we were quite happy. Wow, now we're on the way, on the right track here. But then the patient got worse. She was basically bedridden with dyspnea. And the physiotherapist contacted me, said he had her in training and said, this is strange, she's getting worse, something's wrong. And I called the patient, and she was clearly having conversational dyspnea just by talking to me lying in bed. And she had been at the emergency department twice because she couldn't breathe. And they didn't find anything wrong with her lungs or heart. So we took a step back, and then we did the orthostatic test, 24 hours electrocardiogram, and the 24 hours blood pressure. And she had POTS, she had inappropriate sinus tachycardia, which she hadn't had any symptoms from the heart, and hypotension. So we treated her with ivabradine and midodrine, and blood pressure and pulse and breathing normalized. And after a few weeks, she was back to work at the children's department. So now we always screen for POTS, regardless of the symptoms. Because POTS can give you extreme fatigue, and especially POTS with low blood pressure, extreme fatigue without any orthostatic symptoms, really. Yeah. So I will mention something also about our research. You already heard from Marcus Buggert, our immunologist, yesterday. It's a CLIMP, it's a study called Clinical Immunological Factors in Post-COVID. It's a longitudinal cohort study of our patient population. We look at immunology, symptoms, functions, and disability, and also related to clinical findings. And also we are planning for a probiotic study, treatment study, and a study of brain FDG-PET. So this is from what Marcus presented more yesterday, that we found that breathlessness in post-COVID patients was related to inflammatory networks. This is interesting. And this is from a poster of our PhD student, Elsa Beteus. She presented it just, I think, some weeks ago in Berlin at the meeting. So here we could see that the symptom profile with the patient, with the post-COVID patient, was related to their functional disability. So especially fatigue, cognitive difficulties, exertional breathlessness, and PEM. They were highly interrelated, these symptoms, and strongly associated with greater functional disability and poorer health-related quality of life. And the very high prevalence, you also used the DSQ-PEM. We had a high prevalence of ME/CFS-like features. More than 50% of the patients seem to fulfill ME/CFS criteria. PEM is quite common in this population. For us also, like you heard before. So it's interesting to be able to combine the research of like functional disability, and also you see breathlessness also turns up when we look at the more immunological studies as a key factor, and here it also comes into relation to the physical function. Yeah, I had some previous experience of FDG-PET in ME in small samples. We didn't do publication. This is a ME patient with PEM and significant cognitive impairment and brain fog. And we see reductions in neuronal function in the lateral temporoparietal cortex bilateral. You can see here, which is not red enough here. This is the front of the brain, this is back. It's a bit, should be more red activity. And you can see this is a statistical analysis compared to a normal group. These blue areas are too low. There are some reports about this that has been published. The typical thing is that this patient have all other routine lab tests are normal, including standard brain MRI. But you can see this with a routine FDG-PET scan correlating to the patient's cognitive problems. Now we have possibility to do it more systematically. So we have examined around 80 patients so far, and we are a bit surprised that around 90% have reduced regional neural activity in a routine scan. So we're just now doing data analysis. Here it's in black and white, but you see the same here is in the medial temporal lobe. You see there should be more white here. It's quite low glucose uptake, which reflects the neural synaptic activity. So this is one example, a post-COVID patient, 32 years old. It's also severe POTS that improved with treatment, better physical function, and better blood pressure and pulse, but still PEM and severe brain fog, cognitive impairment. So the POTS wasn't the only problem. There's some other component in the post-COVID ME-like. And all lab tests and brain MRI normal, but the FDG-PET routine exam showed reduced neural activity in the medial temporal lobe. So we think this is an important biomarker in a way to better understand why, especially this cognitive effects of some patients. One hypothesis is that the vascular reserve, because of the brain, blood flow changes all the time depending on which area should be working. So if you start moving your finger like this, this area in the brain increases the blood flow between 15 and 100%. And if this vascular tone is not working, maybe the cells doesn't get the energy they need. So maybe the culprit here is in the vessels, like has been discussed previous this week. Yeah. At Karolinska, we also have now a post-COVID research network at the university, which is good. There's several groups doing research on post-COVID, which is also closely related to ME. So it's a boast for us. This is a homepage. Let's see, like this. Yeah, that was my last slide. Thank you very much.